chilly morning in Houston, Texas. We don't usually have cool weather like this, and so I think majority of us are enjoying being able to wear clothes that are winter type clothes, though. So, and today Dr. Corey Walker with Meningers right here in Houston has come back with us again, and she was here a few months ago talking about all kinds of different disorders, bipolar, schizophrenia, etc. And we didn't really have as much time as we would like to talk about each one. So, good morning, Dr. Walker. How are
Good
you?
morning. I'm doing well, Evelyn. Thanks for having me.
Good. Yes. Well, we're thrilled to have you back again,
Thank you.
and it wasn't too far a drive for you. Meningers is just down the road from
It
here,
is. It is.
which
It
is
is just down the road.
wonderful.
Yep.
And we are so very lucky to have Meningers in our backyard, actually, too.
Yes.
So,
Yeah.
one of the top mental health institutions, I guess you would say, in the United States.
Yes.
Which
It
is
is.
wonderful.
Yeah.
But we didn't have time last time to get to know you very well. So tell us about your background and where you're from and how did you end up in Meningers and what is your exact title? And I know I don't think we have enough time to say what do you do there, but that would probably take a week or so to tell just what you do.
Well, thanks, Evelyn. I appreciate that. I did the majority of my growing up in Wyoming, so I say I'm from Wyoming. And I actually was interested in psychology initially and ended up having my first career in business in England. So I kind of have had a winding path coming to medicine. And realized that my interests really, like when I had my free time, I was looking into medical things. And so I ended up going to medical school and I elected to go to osteopathic medical school. And the easy way to describe it, which would make true osteopaths roll over in protest, but the easy way to describe what an osteopath is an MD and a chiropractor all in one. And so that gave me a whole other set of tools in my toolkit, and I really liked that. And then during the course of my training, of course, there's always a patient that influences you, and I met a
Right.
patient who really needed someone who understood internal medicine and understood psychiatry both.
Right.
And I thought there should be someone like that. And I was applying for residency, and lo and behold, there are combined residencies in internal medicine and psychiatry. So I went to the Medical University of South Carolina to do my training in internal medicine and
That's great.
psychiatry.
Yeah.
And worked there for a while, and then an opportunity came open to interview at the Menninger Clinic, and in the field, Menninger is legendary, and so I was very
Right.
humbled to have the opportunity. It was we clicked well, and it was also an opportunity where I get to use both of my specialties. I do psychiatry most of the week, and then I am part of the internal medicine team on the weekend.
Right, which makes sense too, because so much of the psychiatry part or mental health issues can affect your body and how it all, because obviously it all works together.
It does.
Yeah.
It does all work together, or sometimes it doesn't,
Doesn't
work
work
together.
right. And that's where you come in to
Yeah.
help that person learn how to deal with that. Or
I was very lucky. They had an opening on the assessment unit, so I also get to use all of my training there while I'm trying to figure out what's happening for people that they've ended up kind of stuck in their
Right.
life, or this has come on suddenly and just really knocked them off their balance. Because in the assessment unit, we look at psychological reasons, we look at psychiatric
Right.
reasons, we look at medical reasons, and we do find things. Undiagnosed rare disorders or undiagnosed brain tumors. So it's been a
Interesting.
great opportunity. And then over my
Right.
time there, I've advanced to be the program and medical director of that assessment unit, which means I do some administrative work and I also keep working with patients. So that's
And I'm
where
sure
I am
that
now.
I know the administrative part's not always fun, but working with the patients is, I'm sure, just getting to know you, that I have gotten to know you, that's the best part, of course, is seeing how you can help people.
Yes.
And
yes.
when you see what they're going through, and then they get the help that they need, and just seeing that must be such a
It's
pleasure to
very
you.
humbling to be in a position where people do tell you what they're going through. It's
Right.
always a privilege.
Right, and it's it's one in every four families is affected by some type of mental health issue.
Yes.
And so I'm glad that so many of you are tuning in, because there's so many people out there that, like I said, have family members or themselves or someone else, and it does affect your life.
It does
you know,
affect
and
your life.
everything you do every day and how you feel and so on. So we're very thankful for you, and like you said, Menninger's right here too, and being able to do all of that.
Wonderful.
And of course, I'm glad to have you back again.
I'm glad to be back again. Thank you.
And Managers is glad to have you too. I mean, they're lucky to have you.
Oh, well, thank you.
And I'll call them and tell them.
Well, I feel really lucky to be there. So,
Because I do know the new CEO, and he seems wonderful,
yeah.
and he's going to do
He's a
great
very
things there
energetic
too.
guy with lots of
Uh-huh.
ideas
Good, good.
and lots of interest and lots of compassion. So,
Yeah, and that's the important thing too.
Yeah.
And I guess we never had a chance to talk about this before, but I'm from Wyoming also.
oh wow.
That I did not know that you were from Wyoming. We're the only two people that have left Wyoming, right?
I know. Yeah, it's very rare to run
Yes,
into another
right.
Wyomingite.
And I was actually born in Lander, Wyoming.
Oh, were you really?
Yeah,
Well, I grew up in Cheyenne.
Yeah, yeah.
So
Oh,
not
okay,
too
oh,
far,
gotcha,
not
okay.
too
And
far,
I grew
just
up in
down the road.
Riverton, which was like kind of a farming
That
community
one,
and
yeah.
that kind of thing. Yeah. So and
Yeah.
but I don't know about you, but of course, I went to college and then left pretty much right after that, and so on. And now that I live here, I don't think I could handle that cold weather all the time anymore. I guess you living here where it's a warm majority of the time, and I remember those snow days and mini snow, lots of snow, and you couldn't drive very well and all kinds of stuff. So anyway, let's go ahead. Another Wyoming night here. So yeah, that's great. So let's go ahead and start talking about bipolar.
Sure.
I know a lot of people come to me and ask me about that, and that's one of the disorders, of course. And I think it is a difficult one, possibly. But you're the expert. So is it difficult to diagnose? And tell us. Let's start off. What is bipolar?
Sure. So, bipolar disorder is where people will suffer periods of depression, and they will have had at least one manic episode in their lifetime. And I think people know what depression is, but let me kind of encapsulate what clinical depression is. So, clinical depression will be, it will kind of happen, there's not necessarily a reason for it. Now, a lot of times it can come in a period of stress, but that's more a matter of we've gotten worn down and we don't have the neurotransmitters we need. And so, depression ends up being a disorder of your environment and possibly relationships, and as well as brain chemistry. And what can happen with that is that you can have low energy.
Right.
You don't enjoy things that you used to enjoy. You might talk really slowly or have a long time before you can answer things. The world might seem very gray. You might have very dark thoughts. You might your focus will be on negative things, things that have gone wrong, things that you've missed, things that people said to you that were negative, or insecurities you have might become part of your ruminations. And people actually can get so depressed that they don't leave the bed, that they are hearing things that aren't there. So it can get very, very severe.
Right.
This is more than having a downtime or feeling run down or being sad. It is a clinical condition, and one of the things people forget is with mental illness, it too can be fatal. And if you don't get treatment, one of the natural outcomes without treatment for a mood disorder can be death. And it's important for people to realize that importance, and how that's different than just being sad. Because a lot of times, just being sad or being down or
Right.
having a rough time is probably not going to end up in your death. So that's depression.
Okay, when you say death, you mean that someone may consider taking their life by suicide?
They may take their life by
or
suicide. They may
other-
take risks, and not think about what's going on. They may be self-medicating and inadvertently overdose. They may just not take care of themselves to the point that they die. Like they get a wound and it gets infected. They get a bladder infection. They don't get it treated. They get septic. So
Things like
all
that.
kinds
I see.
of things
Yeah,
can happen.
gotcha. Because a lot of
Yeah.
times they don't want to leave the house, like you said, leave their bed at all, and that type of
Correct.
thing. So, and
Correct.
can you explain to our audience also what is a manic episode?
Right. So, mania is also a disorder of the neurotransmitters as well as the electricity and how it's functioning in the brain. And there's a lot of other factors that contribute to bipolar disorder and mania that we don't understand.
Mhm.
A manic episode will usually start out
Mhm.
where someone feels great, and they have a bunch of
Mhm.
energy.
Mhm.
They may be
Mhm.
really productive. And I think we've all
Mhm.
had these days where,
Mhm.
for
Mhm.
whatever reason, we are
Right.
on and we
Mhm.
have tons of
Mhm.
energy and we're just
Mm.
boom, 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 boom. We're nailing
Right.
it, and we feel
Mhm.
great.
Right. Everything's
And
going just right.
right. And
You're
that can
feeling good about it too.
exactly. And then that can
Yeah.
continue and it
Mhm.
can
Mhm.
accelerate to where people start having tons of ideas and they're coming really
Mhm.
fast. And they might
Mhm.
start one and
Mhm.
then, oh, well,
Mhm.
I don't want to forget this one. So they start this
Yeah.
one and, oh, they want to
Mhm.
start this one. They might start realizing that
Mhm.
they have figured
Mhm.
out
Mhm.
the answer to nuclear fission and
Mhm.
start writing
Uh-huh.
a missive about this and just write and write and write.
Mhm.
People will
Mhm.
often talk
Mhm.
about you're
Mhm.
talking fast, I can't follow you.
Mhm.
Again,
Mhm.
might start many
Mhm.
projects,
Mhm.
might do things that are reckless,
Mhm.
might drive
Mhm.
too fast, might
Mhm.
jump out a
Mhm.
window because they think they're
Mhm.
invincible. And it's not like a
Right.
hallucinatory thing, but it's just kind of like, I'll be fine,
Yeah,
and just
right. Right.
they
Can it
might.
be, well, not simple, I would say the simple things like shopping, spending money,
Right. So
things
they
like
might
that.
be out and use drugs when they wouldn't
Mhm.
have sex with
Mhm.
people they wouldn't normally have sex
Mhm.
with, or
Mhm.
spend a lot of money that they
Mhm.
don't have on
Mhm.
things they don't
Mhm.
need, or
Right.
like decide
Right.
like I like this pup tent, and so I'm going
Mhm.
to get it in every
Mhm.
color it comes in.
Right.
Right.
Right. In
Irritability.
case I go camping
Right.
sometime. Yeah.
Irritability can be a hallmark of
Mhm.
bipolar disorder. And then one of the
Mhm.
main things with
Mhm. Mhm.
mania is that you can go for days at a time without
Mhm.
sleep
Mhm.
and you don't feel tired. You
Mhm.
don't need sleep. You're more
Mhm.
energetic.
Mhm. Mhm.
Now, if a lot of times once you start getting to the point where you're manic, so what I
Mhm.
described before, where
Mhm.
you're really
Mhm.
functional and all that, that's
Mhm.
hypomania.
Mhm. Mhm.
But when you
Mhm.
get to the point of
Mhm. Mhm.
mania, you really lose
Right.
sight of what you're doing and how
Mhm.
you're coming across
Mhm.
and what's happening
Mhm.
to you. And people can
Mhm.
develop
Mhm.
what we call psychosis, and that's where they
Mhm.
lose touch
Mhm.
with reality. So
Ah,
they might
okay.
experience things
Mhm.
that the other people around them aren't experiencing. So they might hear the voice of
Mhm.
God, but no one else is hearing the
Mhm.
voice of God.
Mhm.
And
Mhm.
for them,
Right.
that is what their brain is telling them is happening. So for them, that's
Mhm.
reality. But for
Mhm.
everybody else
Mhm.
around, they're kind of like,
Mhm.
that's not
Right.
happening. And obviously,
Mhm.
that type
Mhm.
of situation
Mhm.
can put
Mhm.
people in danger because you might take
Mhm.
actions based on what you're
Mhm.
believing,
Mhm.
that put you in danger.
Mhm.
Um,
That's coming into your mind is saying that's just fine.
right.
Go for it. But it's your mind talking,
Yeah.
not reality.
Exactly.
Mhm. Okay.
Once you've had one manic episode that
Mhm.
is bipolar
Mhm.
disorder,
Mhm.
even if you
Mhm.
never have another one again and you just get stuck
Mhm.
with the depression,
Mhm.
which is
Right.
such a bummer.
Yes.
But that
That's
is also
true.
common.
Mhm.
That is also
Mhm.
common that people have one
Mhm.
manic episode and then they're
Mhm.
dealing with the
Mhm.
depression. What
Mhm.
you'll find is
Mhm.
people tend to
Mhm.
have about two
Yeah.
mood episodes a year. If it's considered rapid
Mhm.
cycling, they may have 4 to 6
Mhm.
episodes per year.
Mhm.
If
Mhm.
people are up and down
Mhm.
and you never can predict their mood and it's on a
Right.
daily basis, that's
Mhm.
something else. That's not
Mhm.
bipolar disorder.
Okay. Okay.
Um,
Mhm.
Bipolar disorder does require medication
Mhm. Mhm.
initially
Mhm.
to calm it
Mhm.
down
Mhm.
and to
Mhm.
get balanced. People need a mood stabilizer.
Mhm.
And
Mhm.
then,
Mhm.
while best practice
Yeah.
says you don't use antidepressants
Mhm.
in bipolar
Mhm.
disorder, the
Mhm.
reality
Mhm.
is sometimes once people get their
Mhm.
mood balanced, they do need a little
Mhm.
antidepressant.
Mhm.
There's always a risk that
Mhm.
that can cause mania, and that's why you want to have a good dose
Mhm.
of mood
Mhm.
stabilizer on board
Mhm.
first.
Okay. Mhm.
Um,
Mhm.
so
Mhm.
those are kind of the key things
Mhm.
about
Mhm.
bipolar disorder. The
Mhm.
mood
Mhm.
episode will last in
Right.
depression for like 2 weeks or longer. With a manic
Mhm.
episode, we're
Mhm.
looking for like
Mhm.
4 or 5 days of not
Mhm.
sleeping, up to a
Mhm.
week, 2 weeks.
Mhm.
The other
Right.
thing is, it can't be caused
Mhm.
by,
Mhm.
well, you had that bump of cocaine, or you
Mhm.
tried
Mhm.
methamphetamine, or you
Mhm.
overused your Adderall, or you took a bunch of diet
Mhm.
pills. Though
Mhm.
that may or may not be bipolar disorder, and you're
Right.
not going to know unless it
Mhm.
happens in the absence of those
Mhm.
substances. So,
Gotcha. Because those substances by themselves are causing certain
They can
things by
cause
themselves.
exactly.
Yeah,
That could cause anybody to
absolutely.
become
You have to
manic.
right, right,
Yeah.
right,
One of the
right.
tough things about bipolar disorder is, as I started out talking about this hypomania and being,
Right,
it feels great.
right.
It feels great. You can be more creative. You make more connections. You can think outside the box.
Right, right.
And so when I, as a psychiatrist, come and say, let me give you a medicine to stop this,
Mm-hmm.
you can imagine
Understand that
people are
look
like,
like.
you can keep that to yourself.
Yeah,
And of course,
yeah.
they lose perspective. They don't know that the voice of God isn't
Mhm.
talking to them, or that they're actually frightening people, that nobody can make sense of them anymore, that they can't follow them, that, they knocked down a wall in their
Right.
house because they decided they could remodel it
Mhm,
themselves. And, the
mhm,
family's like,
mhm. Right,
what's
right.
happening here?
Surprise, surprise.
Yeah,
What's
and they just
happening?
really
Mhm,
lose, they don't
mhm,
have perspective
mhm,
then. So they're
mhm,
stuck in that,
mhm.
this felt really great.
Right.
And
Mhm,
that's
mhm,
partially
mhm,
why um,
mhm.
people go off their medicines when
There,
they have
yeah.
bipolar.
I think that's one of the biggest things that I hear is that,
Hmm.
whether it's someone's son or daughter or their, like I said, a loved one, wife, husband, whatever, it's well, like they won't stay on their medication.
Yep.
And like you said, that's probably why, because that part
Yeah.
feels good
Yep.
until you have the other part,
Exactly.
the very low part.
Yeah. Exactly.
Mhm,
Yeah.
mhm,
Exactly.
mhm.
And some people will do that.
Yeah,
They'll have a manic episode and crash in
yeah.
depression. Some people will
Mhm,
just, they'll
mhm,
become a
mhm,
normal mood
mhm,
again
mhm,
and
mhm,
go that way
mhm.
for a while and then have a
Right.
depressive episode.
Mhm,
It just
mhm,
depends on the
mhm.
person.
Right. And during that time, like you said, you need to help with medication
Hmm.
to help
Hmm.
balance all of that.
Yes.
I know I'm very adamant about if you need medication, take it.
Right.
I've had so many people that I've talked to that have thought about, taking their life by suicide or whatever. And I've always said that if you need to take it, take it.
Right.
And there's some, people out there that, well, I don't want to take anything. And of course, I work with a lot of veterans and our first responders and that type of thing. And I do realize, with different things like PTSD and that type of thing, that a lot of those medications have a lot of side effects.
Mm-hmm.
And I agree with that. But like you were saying with bipolar, you need that actually to help balance your brain.
You do. And with the
Definitely,
side
yeah.
effects, that's one thing, talk to your doctor. Say what's
Mhm,
happening.
mhm,
If your
mhm,
doctor
mhm,
won't listen to
mhm,
you, try a couple
mhm,
times,
mhm.
because maybe it's just not
Right,
connecting.
right,
But if
right.
really
Yeah.
there's this pattern of your doctor just kind of saying, like, what you say you're
Mhm.
feeling,
There.
that's not
Mhm.
possible, or you're
Mhm. Mhm.
exaggerating, or you just need to suck it up, um,
Mhm.
you might need to find
Mhm.
another doctor.
Mhm.
Because
Mhm.
medication management and in modern
Yeah.
psychiatry, this
Right.
is a very collaborative
Mhm.
experience.
Mhm.
And I
Mhm.
need that information from the person about
Mhm.
what they're
Mhm.
experiencing.
Mhm.
Now, one of the things is when you're coming down off a manic episode,
Right.
once you feel normal, that feels
Mhm.
depressed.
Mm. Mhm.
And so that might
Mhm.
be a time where I'm telling someone you got to hang in there. But if they tell me, like, I'm
Right.
sleeping 12 hours a
Right.
day,
Mhm.
I
Mhm.
can't get up
Mhm.
before 10
Mhm.
in the morning, I'm going to bed at 8 at
Mhm.
night,
Mhm.
that's a
Mhm.
problem. And we need to
Mhm.
look at other
Mhm. Mhm.
options. If
Mhm.
you're putting on a lot of weight,
Absolutely. Mhm.
you might
Mhm.
need to look
Mhm.
at another
Mhm.
option.
Mhm.
If you
Mhm.
lose
Mhm.
sexual
Mhm.
function, that's
Mhm.
also a huge
Mhm.
problem.
Mhm.
And
Mhm.
there are
Mhm.
medications that we can try different
Right.
things to try to
Mhm.
get something that
Mhm.
has fewer side effects. And,
Mhm.
if we're
Mhm.
really fortunate, no side
Right.
effects. You just get the
Mhm.
benefit.
Mhm.
So,
Mhm.
if the
Mhm. Mhm.
person can be patient
Mhm.
with sometimes
Mhm.
having to have a
Right,
lot of
which is
medication
hard.
trials,
Yeah.
and they have a doctor who will work
Mhm.
with them,
Mhm.
you can keep
Mhm.
you can keep
Mhm.
chipping
Mhm.
away at it till you get the most
Mhm.
tolerable
Mhm.
regimen possible.
Right, and I think that's one of the frustrating parts about the medication with mental health issues is, for example, if you have a sinus infection or something like that, you get an antibiotic, and within 10 days or so, you feel better, and so on. But it is it's usually about 6 weeks before you
Mhm.
know which medication
Mhm.
is helping or is not, and like you said, side effects, and some of them you have to just get used to a little bit,
Mhm.
that type of thing. And so that is frustrating,
Yeah.
but in the long run, it's worth it when you do find that
Right.
one. And
And
as
your
you
example of
know,
a sinus
yeah,
infection is
yeah,
perfect.
yeah,
Because
yeah,
people who get
yeah.
chronic sinus infections or get them
Mhm,
repeatedly, they start
mhm,
getting that
mhm,
antibiotic
mhm,
and it
mhm.
doesn't work.
Right.
And so then they have to try another antibiotic.
Mhm,
And then that
mhm,
one maybe
mhm,
partially works, but
mhm.
this time they've been on two
Right.
antibiotics, so now their stomach is upset and they're
Mhm,
having symptoms
mhm,
with,
mhm,
their bioflora, being messed
Right.
up.
Right.
And then it's like it's not quite right, so then they have to try another
Mhm.
antibiotic, and then they
Mhm.
finally do feel
Exactly.
better, but it's been 6, 8 weeks. So that's a
Mhm. By
that's a
then.
perfect example.
Mhm. And I always say your flora and fauna in your stomach.
Yes.
Yeah. You might as well, in mental health, you have to laugh sometimes too. You really do. So
Absolutely.
it's just like
Absolutely.
kind of like in nature. Are these plants working well with this one? That's what your stomach's like.
Yeah.
It's sometimes you add other things to it, and it does not like that.
Right, right. Exactly.
And that can a lot of medicines.
Yeah.
I know with different medications I've taken in the past is that it says take before dinner or right or
Right.
afterward or whatever. And I know with my stomach, anything like an antibiotic, I have to take with food.
Mhm.
So you learn those
Yes,
things, and
yes,
it
exactly.
still got rid of the
Right.
sinus infection
Still
or
worked.
whatever.
Yeah.
So it still worked. Yeah.
Yeah.
So
Yeah.
I think it's all about kind of helping yourself with that too. So
Yes. Yes.
definitely. So if I were to come to Meningers, for example, and say, here's what's going on, there would be an assessment, or tell me the process that you go
Sure.
through.
So, some people might say, like, it kind of depends on when you notice it and how far along the path you are. But we do have a lovely group of people who take the calls, and you kind of give them a little snippet
Right.
of what's happening with you. Maybe things are like, I haven't been to work in 2 weeks, versus like, my energy is really poor, or my energy is really high and I can't
Right.
focus. And so that'll help them know, should we try to skirt you to the inpatient side? Should we look at the outpatient side? Whatever.
Right.
So they'll kind of get you to where you need to be. And if they're uncertain, we have a whole admissions team that are clinicians, and they will ask you more detailed questions. So you will be sharing personal information. The admissions team are clinicians, and and
Right.
everybody at Menninger is bound by
Right.
confidentiality.
Mm-hmm.
So just to say, but it's weird, it's on the phone. You haven't met these
Yeah,
people. They're asking you
right.
questions. But
Right.
anyway, based
Yeah,
on that, they can
right.
tell you maybe you only need outpatient care, or maybe you do need inpatient care. So that's the first thing. And usually inpatient care is going to be things like you haven't been able to make it to outpatient appointments, you haven't been able to stay on your medication for whatever reason. Maybe you've been too sick.
Right.
You know, if you aren't being able to function, like, make your meals and take care of yourself, or of course, if you
Right.
are thinking about harming yourself, we're going to bring you in so you're safe. If you're
Right.
kind of still making it, we might look at doing other things that you don't come into the hospital. What we try to do, ideally in all of mental health, but definitely at
Right.
Menninger, is that we look for the least restrictive, effective method. So
Wonderful.
if the
That's
least
good to know.
restrictive is you need inpatient, then we'll tell you. If we think, hey, here's this great day program that you could
Right.
go to, and you can do that, or maybe an evening program, or just a therapist, we can advise you, and we want people to
Yeah.
have the support they need and not more than that, right? So if they get selected for outpatient, they might choose to do an outpatient assessment. They might be seeing a therapist and a psychiatrist. What you kind of typically
Right.
think of. If it's inpatient, they'll advise you what unit might work best for you, and then you'll select an admission date, and they'll send you what to pack and all that good stuff. Come to Menninger, you're greeted,
Right.
you meet the admissions doc, and then you're brought back to the unit, and we get you settled, and we get to work. So it's a very collaborative approach. There's psychologists, social workers,
Right.
physicians,
And every person there.
nurses, mental health
Right.
associates. So you have, and everybody's part of the team. And most important, the person coming in for help is part of the team.
Right.
If I don't have your information, my education and experience is useful, but it's theoretical.
Right.
It only comes to life to the degree that the person seeking help is an active member of the team.
And I think, like you said, from the second you make a phone call, even that those people truly do care about you,
Yeah.
and that is everyone that's employed there or whatever truly does care and really wants to help you.
Yeah.
And I think if you think of it that way, also, that helps you more too.
We get some really valuable insights from our housekeeper.
Uh-huh.
You know,
Uh-huh.
she's
Uh-huh.
sometimes she's around and people don't notice
Yeah.
her,
Mm-hmm.
but she's paying
Mm-hmm.
attention. She knows
Mm-hmm.
everybody's
Mm-hmm.
name. She
Okay,
might
so if you go there, watch out for the housekeeper. No, just kidding.
she might hear that you're crying on the phone, and you know everybody's
Mhm,
busy up
mhm,
front, whatever, and she'll come
mhm,
out and say,
mhm,
"Hey,
mhm.
I just want you to know when I walk by this room,
Right.
this person was crying."
Mhm, mhm,
Another
mhm,
time, you know, someone had made a
mhm,
noose out
mhm,
of their sheet and put it under the
mhm,
bed,
mhm,
and the
mhm.
housekeeper
Wow.
found it. And it really
Mhm,
gave us an
mhm.
opportunity to help because the patient didn't want to
Right.
make people feel bad
Right.
that they weren't feeling better.
Mhm,
So I
mhm,
hadn't spoken up.
mhm,
And as you can see, then it
mhm,
doesn't work. It
mhm.
just doesn't work.
Right,
You know,
because you
if it's
truly have
right.
to say exactly
Yeah.
how you're feeling. Yeah,
If what we're
yeah,
doing isn't
yeah.
helping, say so.
Right, right, and tell us.
You know?
Yeah, yeah, because we can't. I always tell people I can't read
Yeah.
your mind. I mean,
But
there's many times I don't want to read people's minds, but there's a lot of
but
times I can't read your mind. So
yeah.
tell me what you're
So
thinking and
that's just a way
feeling.
to too
Yeah.
though to exemplify the team aspect at Menninger.
Mhm,
You know,
mhm,
from
mhm,
our
mhm.
maintenance staff and our housekeepers all the
Right.
way up to our administration.
Mhm, mhm.
So everybody's
And
part of
that's
it.
good to know.
Mhm.
Definitely. Now, when you say units, what does that mean?
Sure. So we
Mhm,
have
mhm,
5
mhm,
different
mhm, mhm,
units on the
mhm,
hospital.
mhm.
So, and they're
Okay.
actually little
Okay.
pods, almost like the
Mhm,
hospital's kind of arranged in
mhm.
a clock shape almost.
Uh-huh.
And we
Uh-huh.
have one unit that really specializes in
Mm,
adults who have been
mm,
battling mental
mhm,
health issues and
mhm,
relationship
mhm.
issues for some period of time. They work on
Right.
treating that. We
Mhm,
have
mhm,
another unit that also has
mhm,
treatment, but really focusing on
mhm, mhm,
professionals,
mhm,
people in
mhm.
hard charging careers or people in
Right.
professional schooling,
Mhm,
kind of
mhm,
working with
mhm.
that type A group,
Yeah,
which, you
that's right.
know, they need to kind
Mhm,
of be by
mhm.
themselves.
Yeah.
We have our emerging adults group, and that's
Mhm,
people
mhm,
18 to 30
mhm,
who,
mhm,
you know,
mhm.
have maybe gotten through high school and made
Right.
several attempts at college and it's just not working, or they don't want to do
Mhm,
college and there's just this
mhm,
battle, but they just can't quite. That transition
mhm.
to the next step is
Right.
really challenging. Maybe some substances have gotten in the way.
Mhm,
Maybe there's been
mhm,
a relationship that took you
mhm.
out of commission. So
Right.
that's what that unit
Mhm,
does. And we have an
mhm,
adolescent unit
mhm,
who
mhm,
also
mhm,
does assessments as well
mhm,
as some of the treatment for, again, substance use disorder,
mhm,
relationships
mhm,
issues, and
mhm,
of course, trying to help the family system. And then the unit I'm
mhm,
on is an assessment
mhm,
and stabilization unit. So,
mhm,
on one hand, we do
mhm, mhm,
assessments for
mhm.
people, again, who have, like, I've been told 6 different diagnoses,
Right.
I've been on 20 different
Mhm,
medications, I just want to know what's
mhm,
happening and get, like, let's once and for all get a
mhm.
treatment plan that
Right.
I understand
And get it
that
figured
I want to
out.
participate
Yes,
in
yes,
and
yes.
and get that to
Mhm,
work.
mhm,
And then we
mhm,
also have a
mhm, mhm,
stabilization where maybe someone comes in manic and needs some
mhm,
support
mhm,
to kind
mhm,
of rein them
mhm.
in and help get
Right.
medications on board. Maybe someone's suicidal and they need
Mhm,
some time to just
mhm,
kind of feel
mhm,
safe.
mhm,
Maybe someone has a real hard time changing meds. And so they just want to be in a
mhm,
supported
mhm.
environment to kind of make a med
Right.
change. And that's our
Mhm,
stabilization side.
mhm, mhm,
And really
mhm,
with that,
mhm,
there's not like the other
mhm, mhm,
units you're looking at 6 to 8 weeks. My unit for an
mhm.
assessment is
Yeah.
about 3 weeks.
Mhm,
But
mhm,
stabilization is
mhm.
clearly just based on
Right.
clinical goals. We're looking for
Okay.
someone to
Okay.
feel
Yeah.
better, be
Right.
stable,
Right.
um,
Mhm.
have a safe place to
Mhm.
go, and a good
Mhm.
discharge plan.
Mhm.
And once that's achieved,
Mhm.
they
Mhm.
leave. So if
Mhm.
that's in
Mhm.
three
Mhm.
days,
Right.
they leave in
It
three
depends on
days.
how it
If that
goes.
takes
Right.
two
Yeah.
weeks, we take
Mhm.
2 weeks.
Mhm.
You know, if that takes
Mhm.
two
Mhm.
months, we take two
Mhm.
months. Whatever
Mhm. Mhm.
whatever it
Mhm.
takes to kind of achieve those clinical
Mhm.
goals.
And like you said too, with the medication, with the stabilization, then if you're there, it can be monitored and
Mhm.
you can say all day long how you feel
Exactly.
and report in on this is
Exactly.
happening or this is happening or
Mhm.
whatever. And
Yeah.
so that's a good thing also. Are
Mhm.
there any other thoughts here? We have just a couple minutes left here. Oh, that went fast. We have 1 minute left here. I'm looking at my clock, so I always end up talking too much. And so I guess the last thing I'd like to say is that for all of you that are viewing and tuning in, that there are any other topics that you particularly want to hear about. Dr. Walker will be coming back in May, June, and July on the first Thursday of each one of those months. And we will be doing a series about different areas. And so if there's an area that you yourself are dealing with, or a family member, or a friend, or whatever, let us know. We've got an
Yeah.
expert here with a great background, and she's okay if she's from Wyoming too. So, you know. But anyway, please do just call the station, let us know. So thank
Absolutely.
you so much for coming again. It was
Thank you
great
for
to see
having me. It's
you.
so fun, and it's great to talk to people. I
Yeah,
appreciate it.
yeah,
Yeah.
definitely. And you all get to hear that there is help out there, and never, never give up. There's always hope. And so we will see you next week. Thanks for tuning in. Bye bye.